Buenas tardes a todos. Bueno, vamos a ir empezando, 5 minutos de cortesía. Y bueno, solo puedo empezar agradeciendo a Chiesi por organizar esta reunión, por darme la oportunidad de compartir moderación con el doctor Álvaro Agustí y mesa con el resto de ponentes. Os voy a comentar las 3 ponencias y presentar a sus autores. Luego hablará cada uno de ellos y haremos, si os parece bien, una discusión conjunta al final. Empezará el doctor Juanjo Soler, del Hospital Arnau Vilanova, aquí de Valencia. Enhorabuena por el Congreso, Juanjo. Mucho nivel, nos estás poniendo a los bilbaínos la cosa difícil para el año que viene. Y el doctor Soler nos va a hablar del concepto del control de la EPOC, qué sabemos y qué nos falta por saber. Posteriormente, el doctor Dave Singh, que es profesor de Farmacología Clínica y Medicina en la Universidad de Manchester, nos presentará estrategias para mejorar el control de la EPOC que nos propone Gold. Y, en tercer lugar, el doctor Omar Usmani, también profesor de Medicina Respiratoria del Imperial College de Londres, hablará del rol de la pequeña vía aérea en el control de la EPOC. Así que, sin más, le doy paso al doctor Soler. Gracias a todos.
Bien, buenas tardes a todos. Gracias, Patricia, Álvaro, por la presentación. Por supuesto, muchas gracias a Chiesi por la organización del evento y por invitarme aquí a mi casa, como dice Patricia. A mí me han pedido que les hable del concepto del control y además con el desafío de presentarles qué es lo que sabemos hasta ahora de este concepto y qué nos queda por saber. Este es mi conflicto de intereses y probablemente cuando ustedes piensan en control, concepto de control, pues a alguno de ustedes igual les viene a la cabeza un mando como este, ¿no? Desde el que uno puede controlar los distintos canales de televisión de su casa. Pero quizás a otros les venga a la cabeza algún concepto como esto de los controladores de avión, donde ellos tienen su pantalla en el que pueden de alguna forma controlar el tráfico aéreo. ¿Para qué? Para que todo fluya, para que todo esté en condiciones, para que todo esté correcto. O el piloto de avión que también utiliza ese mando de control. Este concepto, esta idea, el doctor Agustí, ya hace algo más de una década, nos la plasmó en un paper muy elegante, realmente conceptualmente, como casi siempre, muy atrevido y yo creo que innovador en aquel momento, el que nos proponía que para abordar el EPOC tuviéramos que pensar, o estaría bien que tuviéramos ese panel de control. Ese panel de control en el que hay una serie de variables clínicas que nos gustaría tener controladas, un poco digamos, bajo una situación perfecta, pero también nos hablaba de que en ese concepto deberíamos, dentro de la EPOC, tener un buen control sobre la actividad biológica subyacente o sobre la progresión o alteraciones funcionales de la enfermedad. Este fue el concepto y la idea un poco que nos transmitía era, bueno, si nosotros somos capaces de monitorizar todas estas cosas, podemos ir actuando sobre ellas para tenerlas todas en verde, tenerlas todas bajo control. Esta fue la idea conceptual, sin embargo, detrás de esto, bueno, pues empezamos a pensar, oye, vamos a pensar inicialmente cómo esta idea se puede llevar a cabo, se puede materializar y podemos de alguna forma tener una visión más clara del paciente y cómo podemos actuar sobre él. Y en este sentido, pues con un grupo realmente de amigos empezamos a pensar hace tiempo en el concepto no amplio de panel de control, sino el concepto de control clínico. Y con Marc y con Nino, a raíz de un congreso nuestro, de una reunión de invierno donde se nos propuso este debate, bueno, pues empezamos a darle vueltas y realmente al final de bastante pensar llegamos a definir el concepto de control subrayo clínico como el mantenimiento a lo largo del tiempo de una situación de bajo impacto clínico. Si se fijan, este concepto, esta definición así plasmada, trae a la luz 2 ideas. Primero, tener controlado a un paciente. Lo deseable es que este paciente tenga un bajo impacto clínico, perciba poco su enfermedad, se encuentre bien. Para eso vamos a utilizar una serie de elementos clínicos. Pero por otra parte, nos interesa que eso se mantenga a lo largo del tiempo. Y este es el concepto de estabilidad. Como ven, hay un eje transversal, conseguir un buen impacto clínico, que el paciente perciba poco su enfermedad, se encuentre bien, pero además que se mantenga a lo largo del tiempo, es el concepto de estabilidad. Y así definimos el control como la necesidad de cumplir con estos dos conceptos. De una forma muy gráfica, en el artículo original donde plasmábamos la idea, nosotros decíamos, imaginen que ustedes tienen un paciente en la consulta y ese paciente no se encuentra bien. Probablemente tiene un alto impacto clínico. El objetivo terapéutico es que mejore, que ese paciente perciba poco a su enfermedad, que tenga un bajo impacto clínico y que eso se mantenga a lo largo del tiempo. Este realmente es conceptualmente el concepto de control. En ese primer artículo de posición, nosotros ya sugeríamos una propuesta, un cuestionario de control clínico, una serie de variables que nos permitirían evaluar este concepto que les acabo de presentar. Aquella propuesta inicial con unos conceptos, con unos criterios diagnósticos originales, hubo que validarla, hubo que refinarla y finalmente se alumbró de alguna forma 3-4 años después, en el 18, este cuestionario clínico de control, que como ven es una herramienta realmente sencilla, en donde se valoran estos dos ejes que les comentaba. Por una parte, el impacto clínico, y para eso se toman en consideración 4 variables clínicas muy sencillas, fáciles de medir en la consulta, como es el color del esputo, como es el uso de medicación de rescate, como es la actividad física medida de una forma muy sencilla, subjetiva, y también los síntomas, en este caso ajustados por el nivel de gravedad. Para decir que un paciente tiene bajo impacto clínico, el proceso de validación nos dijo que se deberían cumplir al menos 3 de los 4 criterios que tienen en la columna verde. Por otra parte, el segundo concepto, el de la estabilidad, incluimos 2 variables, la necesidad de que el paciente no tuviera agudizaciones en los últimos 3 meses y que además el paciente se manifestase como que estaba bien, estaba igual, no había cambiado o estaba incluso mejor, pero desde luego nunca que hubiera empeorado, porque si algo ha empeorado, por definición no puede estar estable, ha cambiado a lo largo del tiempo. De tal forma que el control, ese criterio de control, exigía que cumpliese los dos parámetros, estabilidad y bajo impacto clínico. Bien, ¿qué sabemos de este concepto, de esta idea que les acabo de presentar? En primer lugar, que como acaban de ver, realmente es una herramienta muy sencilla, absolutamente aplicable en nuestro día a día en la consulta, porque no son más que las preguntas clínicas que ya tradicionalmente hacemos y lo único que hemos hecho es tratar de estandarizarlas. En segundo lugar, quiero decir que aunque este concepto parezca sencillo, durante estos casi 10 años desde que los propusimos, se han desarrollado distintos proyectos de investigación destinados a validar el concepto. Y el concepto realmente está ampliamente validado. Por ejemplo, en este primer estudio, el estudio pivotal de validación, nosotros pudimos comprobar que aquellos pacientes que cumplían los criterios que les he comentado de control, pacientes que están controlados, claramente tienen mucho menos riesgo de sufrir eventos en este caso combinados. El evento combinado era visita a urgencia, ingreso hospitalario o mortalidad, por lo tanto eventos potentes. Repito, un paciente controlado tiene mucho menos riesgos a largo plazo de desarrollar complicaciones. Este estudio se realizó aquí, a 400 metros de aquí, en el Hospital Arnau, un único centro. Pero este segundo estudio es un estudio internacional multicéntrico de varios continentes. Aquí ya hay muchos más pacientes, el objetivo era el mismo, pero tratar de validar, hacer una validación externa del estudio anterior. Y de nuevo los mismos resultados. Un estudio a 3 años vista y de nuevo fíjense que los pacientes que tienen un buen control en azul tienen mucho menos agudizaciones, muchas menos hospitalizaciones, menor mortalidad, menos eventos combinados. En este otro estudio, que es del estudio Chain, es un estudio observacional que conocen bien, realizado en España sobre 900 pacientes que son seguidos durante el tiempo, se pudo demostrar ya en este caso de forma independiente que el paciente controlado tiene mejor supervivencia a 5 años vista. Y finalmente, un estudio a mucho menor recorrido, a corto plazo de tiempo, quisimos ver si esto tenía impacto sobre la calidad de vida. Y ya de entrada ven que los pacientes que están controlados, su CAT es claramente inferior que los pacientes no controlados. Pero cuando lo seguimos en el tiempo, si el paciente persiste no controlado, su CAT no mejora, desde luego puede empeorar, pero no mejora, y tampoco hay cambios si el paciente ya está bien controlado. Pero lo importante de este estudio es que pudimos ver que si somos capaces de inducir un cambio, si somos capaces de ese paciente que no estaba controlado conseguir llevarlo a buen puerto, controlarlo, la calidad de vida mejora. Es decir, se asocia el concepto de control y a estos criterios a una respuesta terapéutica. Y esto fue realmente muy importante, lo mismo pasa en el sentido contrario, ¿no? Bien, por lo tanto, después de ver estos estudios que hemos visto de validación, la principal conclusión es que el control podría ser realmente un nuevo objetivo terapéutico. Si yo tengo un paciente controlado, sé que en el futuro, a largo plazo, mi paciente va a tener menos mortalidad, menos hospitalizaciones, menos agudizaciones e incluso va a tener mejor calidad de vida. Y esto, insisto, no solo a largo plazo, también a corto plazo. Por lo tanto, podría ser potencialmente un nuevo objetivo terapéutico, eso sí, combinado. No es la función pulmonar, no son las agudizaciones aisladas, es todo combinado. ¿Qué sabemos más de esta herramienta? Lo que sabemos es que además es una herramienta bastante sensible al cambio, ya que hemos visto que cuando el estado de control mejora, la calidad de vida mejora, ¿no? Por lo tanto, parece ser. Bueno, aquí hicimos un estudio, en este caso un estudio multicéntrico nacional, con más de, creo que fueron 30 centros participantes, donde vimos cómo cambiaba el estado de control en tan solo 3 meses. Bueno, ustedes ven que las variables clásicas que manejábamos entonces para inducir cambios terapéuticos, que era el nivel de cambio, nivel de riesgo de los fenotipos, apenas cambian. Sin embargo, el control cambia prácticamente en el 30% de los pacientes. Puede empeorar o puede mejorar. E incluso en aquel momento se comparó con GOLD. GOLD también cambiaba, el ABCD tradicional, pero significativamente hay más cambios. Insisto, parece que esto cambia mucho más, pero además cuando se produce un cambio se asocia a una mejoría o un empeoramiento clínico. Y esto fue importante porque nos dijo que esta herramienta puede ser dinámica, puede ser utilizada en cada visita clínica. En cada visita clínica yo puedo valorar si mi paciente está controlado o no, puedo introducir cambios y tengo un objetivo terapéutico a muy corto plazo de tiempo. Esto es relevante porque si miramos, por ejemplo, las últimas directrices de GOLD en el follow-up, en el seguimiento, aquí nos dicen claramente cómo podemos orientar los tratamientos, pero no nos dicen cómo podemos dar un salto de una combinación a otra, de una monoterapia a una doble broncodilatación o a una triple terapia. Esto realmente no está aclarado y no está objetivado cuál es el procedimiento que deberíamos llevar. Recientemente, en su última normativa, EPOC sí que ha introducido este concepto, por primera vez en una guía de práctica clínica, ha introducido el concepto de control precisamente aquí, para sugerir o valorar si es necesario introducir un cambio terapéutico, o al menos para identificar que aquello no va bien, que aquello hay problemas y que tenemos que buscar esto. Bien, el control clínico. Todos estos estudios nos han permitido tener una foto de cómo están nuestros pacientes o cómo estaban nuestros pacientes hasta ahora. Y lo que hemos visto es, en primer lugar, que esto es alcanzable. Por ejemplo, en pacientes con función pulmonar preservada, prácticamente un 60 o 65% de nuestros pacientes tratados alcanzan un nivel de control. En la parte contraria, la parte vacía de la botella, el mensaje es importante, el 35-40% de nuestros pacientes no están controlados a pesar de tener una función pulmonar preservada. Y cuando vemos qué pasa con pacientes más graves, las cifras varían. Esto lo volveremos a analizar después. Pero oscila entre casi un 60 o un 50% a pacientes donde el 30% estaba controlado. Y yo quiero ahora hablarles de un estudio importante que nos ha permitido conocer algo más sobre el concepto de control. Es estudio clave. Es un estudio que lo promocionó Chiesi y desde luego yo les agradezco no tanto la invitación, sino que pusieran en marcha este estudio porque nos está dando una información relevante. Este estudio se hizo para conocer el grado de control de nuestros pacientes antes de que se comercializara la triple terapia en un dispositivo único. Es un estudio cuyo objetivo principal es conocer el control de acuerdo a los criterios clínicos que hemos visto y además, y esto es muy importante, identificar qué factores se asocian al control para ver si somos capaces de modificarlo. Para ello se utilizaron los criterios que les comenté, pero también una escala simplificada donde el impacto se evalúa por CAT, que es sustituir a estas 4 variables, y donde la estabilidad se valora únicamente por las agudizaciones, que sustituiría a las 2 clásicas del control clínico. Este estudio son casi 5.000 pacientes, la mayor parte de ellos de neumología, pero también de interna, de atención primaria, etc. Y la foto fue que en la época de utilización de triple terapia en único dispositivo, el nivel de control era ciertamente muy bajo en pacientes graves, no se llega al 30%. Y que utilizando la valoración simplificada, pues prácticamente los resultados son idénticos. De hecho, el índice de concordancia entre la escala simplificada o la valoración clínica que les presenté al principio es realmente bastante alta. Para mí lo más importante del estudio es que analizó en estos 5.000 pacientes cuáles eran los principales determinantes del control. En esta imagen, que Diego tuvo mucha culpa en ella, Diego, te la agradecemos, se le ocurrió dibujar una diana donde el centro es el control, el objetivo es el control. Y aquí pudimos ver una serie de variables que están muy relacionadas con control. La más importante, la actividad física. Si somos capaces de que nuestros pacientes tengan una buena actividad física, probablemente van a conseguir un buen control. Pero fíjense cómo la adhesión terapéutica también influye, o el nivel asistencial, a mayor complejidad, consultas monográficas, el nivel del control y la comorbilidad. El estudio está dando mucha información. Por ejemplo, uno de los siguientes estudios se subanalizó cuál era el impacto de la comorbilidad. Y aquí teníamos todo ese espectro de comorbilidades o de enfermedades concomitantes de la EPOC. De nuevo, en el centro está el control y aquí tenemos el tamaño de los círculos, tiene que ver con la prevalencia de la enfermedad. Por ejemplo, esto es la demencia, que impacta mucho, lo tienen aquí, la demencia impacta mucho, pero el porcentaje de pacientes es más bajo, ¿no? Pero el mensaje es que, fíjense, casi todas las comorbilidades destacadas impactan en el impacto y muchas de ellas en las agudizaciones. Tenían una puntuación de CAT más de 16. Probablemente debamos destacar a las cardiovasculares, a la ansiedad, a la depresión, a una serie de determinantes. Por tanto, aquí subyace un primer mensaje. Si su paciente no está controlado, miren más allá de la EPOC para ver si hay otras enfermedades sobre las que debamos de actuar. Yo les decía que uno de los segundos determinantes importantes fue la adhesión terapéutica. En el estudio utilizamos el TAI para valorar la adhesión terapéutica y el 40% de pacientes graves no tienen una buena adhesión terapéutica. La mayor parte es por incumplimiento errático, pero hay algunos que lo hacen de forma deliberada y también otros que lo hacen de forma inconsciente, ¿no? Sobre este tema tenemos que trabajar. El último de los papers que está enviado a publicación, no tenemos todavía, trata de evaluar aspectos de adhesión y qué variables influyen en la adhesión. Fíjense que, curiosamente, el que el paciente esté llevado en un entorno de atención primaria o un entorno especializado influye en la adhesión. Quizás porque los mensajes repetidos, la corrección de la técnica inhalada, la educación sanitaria tenga algo que ver. Por lo tanto, el control clínico es alcanzable, pero coincidieron conmigo que es claramente mejorable. Y además hemos identificado una serie de variables sobre las que podemos actuar. Esto es lo que sabemos hasta fecha de hoy. Sabemos bastante, pero necesitamos conocer más. ¿Qué es lo que todavía no sabemos? Yo les presenté la idea de Álvaro de ese panel de control. Y nos hemos centrado fundamentalmente en el control clínico. Lo que todavía no sabemos es la estrecha correlación que puede existir entre las variables biológicas en el sustrato etiopatogénico y el panel funcional. Es muy probable que aquel que tenga más inflamación, más estrés oxidativo, más actividad biológica, que siga fumando, es muy probable que clínicamente esté mal controlado. Pero esto, la verdad es que no lo sabemos y desde luego les animo a que lo investiguen. Y desde luego lo que nos falta por saber es cuál es la influencia de las intervenciones, cómo podemos influir sobre el control. En este sentido, nosotros también en el CLAVE queremos hacer la foto, pero recuerden que el CLAVE es un estudio transversal. Por lo tanto, la foto está desvirtuada. Nosotros lo que vimos, utilizando el esquema de seguimiento de Gold, aquí tienen la línea de disnea y la línea de agudizaciones. Lo primero que pueden ver es que cuando hay agudizaciones, el nivel de control es claramente inferior a aquellos pacientes que únicamente tienen disnea. Y, por ejemplo, si nos fijamos que en la triple, en este caso disociada, el nivel de control es muy bajo. Esto es un estudio transversal, no sabemos si es causa o consecuencia. Es muy probable que estos pacientes sean los más graves y estén utilizando medicaciones más potentes. Y por eso el nivel de control. Pero hay un segundo mensaje y es que necesitamos trabajar más. Claro, si uno trata de ver en ese 70% de pacientes que no están controlados cuáles son los elementos básicos, parece que la esfera inicial, la más importante, es actuar sobre las agudizaciones. En este sentido, tenemos datos recientes, porque esta mañana se lo escuchaba a Álvaro. Es que llegamos tarde, de verdad llegamos tarde. Habitualmente utilizamos los fármacos para evitar agudizaciones cuando los pacientes tienen 2 o más agudizaciones o una hospitalización. Esto, y Álvaro, tú lo comentabas, es como si los cardiólogos trataran a los pacientes después de 2 infartos. Esto no tiene mucho sentido. Bueno, tenemos datos, como les digo, en la literatura que nos dicen que tener, por ejemplo, solo una agudización respecto a no tenerla, claramente aumenta el riesgo de eventos posteriores. Y esto hay que tenerlo en cuenta porque empezamos a tener datos indirectos de que cuando nosotros utilizamos este tipo de medicaciones, la triple terapia en un mismo dispositivo, se reduce las agudizaciones incluso en pacientes que solo tienen una agudización. Por lo tanto, una posible estrategia de mejorar el control sería anticiparnos y utilizar estos fármacos más potentes para prevenir agudizaciones con anterioridad. Esto se ha demostrado en este estudio que mejoraba calidad de vida y además con una muy buena seguridad. Bien, uno de los componentes son las agudizaciones, el otro son los síntomas. Y ahí en los síntomas realmente tenemos algo más de problemas. Esto es un estudio de Bernardino, también dentro del grupo de estudios de control, donde se utilizaron diarios de síntomas. Queríamos desmenuzar qué les pasaba a los pacientes controlados y no controlados en función del diario de síntomas. Y como ven, en general, los pacientes no controlados, en azul, tienen más síntomas respiratorios, más tos, más opresión torácica, tienen más síntomas. Claro, con esto de los síntomas hay que empezar a trabajar y hay que empezar a visualizar las cosas. Si nosotros vemos cómo se comportan los síntomas a lo largo del día, hay una variabilidad en los síntomas. Hoy sabemos, por estudios ya de hace un cierto tiempo, que la mañana es un momento crítico, que donde los pacientes nos dicen que generalmente están más sintomáticos es en la mañana, es un momento crítico. Y eso se ha relacionado con peor estado de salud y con peor calidad de vida, que son desenlaces clínicos relevantes. Pero también sabemos, y esto está menos estudiado y desde luego menos valorado por nuestra parte, que los síntomas nocturnos tienen impacto. Y se ha demostrado que tienen impacto en la mortalidad y en la frecuencia de agudizaciones. Por lo tanto, esto no lo sabemos. Aquí hay preguntas importantes. ¿Realmente estamos preguntando por los síntomas nocturnos, por los síntomas matutinos? ¿Actuamos sobre ellos? ¿La posología que utilizamos en nuestros fármacos puede influir más o menos en el nivel de control? Esto es algo que todavía no sabemos y que debería ser estudiado. Por lo tanto, termino un poco mi presentación. Como resumen, ¿qué es lo que no sabemos? No sabemos mucho del control clínico, pero necesitamos relacionarlo con la esfera biológica, con la esfera funcional y sobre todo necesitamos información del impacto clínico que puedan tener las intervenciones farmacológicas y no farmacológicas sobre el control. ¿Y qué es lo que sabemos? Bueno, sabemos que es una herramienta sencilla, que claramente se relaciona con los desenlaces clínicos más relevantes, las hospitalizaciones, las agudizaciones, la mortalidad, la calidad de vida, y que por lo tanto, y esto creo que es la parte más importante de todo, estamos ante un nuevo objetivo terapéutico, algo alcanzable, potencialmente alcanzable para la mayor parte de los pacientes y que, como hemos visto, es mejorable porque todavía no tenemos un buen control. Y finalmente hemos visto que es una herramienta dinámica y por lo tanto es útil para el seguimiento de nuestros pacientes. Y en este sentido, bueno, pues reconocer una vez más que SEPOC avala y recomienda que utilicen el concepto de control para seguir a nuestros pacientes. Y esto es todo. Muchas gracias.
So it's my great pleasure to give this next presentation, and I enjoyed very much the first one. And I'm going to follow on quite naturally and look at the gold view on some of the concepts that you've already heard about with regard to COPD control. These are my disclosures of interest. So we've already heard about stability and impact, and I'm going to focus in my lecture more on stability. There is a greater importance to achieving stability, and that's the link between exacerbations and mortality. So I show you here a huge analysis from primary care. 100,000 patients. It shows you that the best prognosis is the line in yellow. These are individuals who had no exacerbations. And the worst prognosis is at the top, the line in pink. And these are individuals who had one or more hospitalizations. And then for those community moderate exacerbations, even one event was associated with increased mortality. And then for 2 it was worse, and 3 it was worse. And clearly then, thinking about COPD control, stability is a core component which, if you achieve it, it seems the patients live longer. These are exacerbations. Some of this link to mortality is driven by exacerbations causing cardiovascular events. And we have lots of information on this now. We've known for many years that, as an approximation, about 1/4 of COPD patients die on their death certificate coded as respiratory events, 1/4 cardiovascular events, 1/4 lung cancer, and 1/4 other events. And exacerbations are the cause of some of this cardiovascular death. You see here 2 separate studies. One's a cohort study, the other one's the 16,000 patient summit trial. And they both show the same thing, and I could have shown you other graphs as well. At the onset of an exacerbation, there's an increase in the risk of cardiovascular events, including myocardial infarction. And this happens through multiple mechanisms. At the start of an exacerbation, COPD patients may be hypoxic, they may have hyperinflation, which compresses the ventricles, and that leads to inefficient cardiac output. They may have systemic inflammation, and we all know that inflammation provokes cardiovascular events. So we have plenty of mechanistic explanations for these observations. And again, coming back to control, it means that stability, pharmacological and non-pharmacological management to achieve stability will reduce the chance of these events happening. So because I don't have enough time today, I will now focus on pharmacological management only. And we already heard about the use of inhalers and how best to reduce future risk to achieve stability. Well, here I'm going to focus on the first triple therapy study. So this is the Trilogy randomized controlled trial. This was done with extra fine beclomethasone formoterol glycopronium against ICS/LABA with the same inhalers. So this study tells you what's the benefit of adding the long-acting muscarinic antagonist. I want to just quickly look at the inclusion criteria. There's two things to say about this study. First of all, the patients lacked control. They had at least one exacerbation or more in the last year, so they were unstable. And secondly, to get into the study, you could not be on triple therapy in real life. Now, when this was designed about 15 years ago, this inclusion criteria was at my insistence. Because my view was that this study reflects real life. Because none of the patients are on triple therapy, they're all on single or double treatment, they're symptomatic, they're exacerbating, and in real life, you may choose to step them up to triple therapy. There is no right and wrong about designing these clinical trials. There are different ways to do this. But my view was, an added problem was that if we included patients on triple therapy, inevitably, people would say afterwards that some of your patients stepped down from triple therapy, and that's exactly what's happened with the subsequent triple therapy studies. So we avoided that issue, and in a series of studies, the Trilogy study I've shown you the design, the Tribute study you've already heard mentioned, where the comparator was dual bronchodilator, and the Trinity study, where the comparator was LAMA, exactly the same inclusion criteria were used. And this led to very consistent results. For triple therapy, the rate of exacerbations per year was approximately 0.45, and there was a higher rate with all the comparators, the most commonly used single and double treatments, and the exacerbation rate reduction ranged from 15 to 23%. And this means, as a generalism, if the patient is unstable, to reduce future risk, to give you the best chance of achieving control, you should consider using triple therapy. Then came the other triple therapy studies, IMPACT and ETHOS, and I'll just show you ETHOS. So this is a different triple therapy, fluticasone furoate, umeclidinium, and vilanterol. It's done in a different population. So the patients included here, more of them had a history of 2 exacerbations. So you get slightly different results in terms of the absolute exacerbation rate, but the pattern is the same. Triple therapy reduced exacerbation rates more than the double therapies here. So I want to come back to mortality. And in fact, all the triple therapy studies done in patients with a history of exacerbations are relatively consistent that triple therapy reduces exacerbations better than the comparators. So what about mortality? So this is a hot topic because the statisticians and the regulators will say none of the studies had mortality as a primary endpoint. And to get a regulatory label, it's for a single product. Now, I assume nobody in the room is a statistician or a regulator. We are all clinicians, and we are allowed to look across studies, put the data together, and see if there is a pattern. So let's do that. We have IMPACT and ETHOS, where mortality was a predefined endpoint, although not the primary endpoint. And then we have Trilogy, Trinity, and Tribute, where a pooled post hoc analysis was done. So we actually have in IMPACT 10,000 patients, in ETHOS 8,000 patients, and in the pooled analysis approximately 6,000 patients. These are large analyses. And the absolute reduction in mortality is very consistent across all the analyses. It's about 0.7 to 1% per year. Per year. And it's approximately a 30 to 50% reduction in mortality. And interestingly, at the bottom, when you look at the non-respiratory mortality, which was mainly cardiovascular, there's a 35% reduction. For these analyses, let's ignore the p-values. Some of these are nominally significant, some of these aren't. There's a consistent pattern here, and I put it to you that if you believe exacerbations cause mortality, then you must believe that reducing exacerbations reduce mortality, and then triple therapy gives you the best chance of reducing mortality. And that's certainly the gold view, taking an overall view, which regulators and statisticians don't do. We can take an overall view as a class, single inhaler triple therapy, in this population of symptomatic exacerbating patients who are already on inhalers, then triple therapy versus dual bronchodilator, and it's the ICS component, reduces exacerbations and reduces mortality. And this gives you an idea what can be achieved through the stability component of control. So I want to come back to the GOLD algorithms, some of which you saw earlier. GOLD was redesigned, redrawn, if you like, at the end of last year, and C and D, for simplicity, were removed, and Group E was put there. And we hope you find that easier to follow. And then for simplification purposes, ICS-LABA was removed as well. It's a simplification, but also on the basis of the data you've already seen and the long history of data, we know that LAMAs are very good treatments. If you decide in real life to put a patient on ICS-LABA, there's nothing wrong with that decision. But it's like giving your patient a silver medal when you could have given them a gold medal, because there's very little downside in giving them an extra LAMA. So I would say that the new GOLD algorithms are more aggressive, trying to get the patient on the right treatment sooner. And that's one of the reasons for the removal of ICS-LABA. Again, I repeat, there's nothing wrong with that class of drug. It just happens if you decide the patient needs an ICS, you may as well go to triple therapy sooner rather than later. When we look at the follow-up algorithm, again, for simplification, we've removed ICS-LABA. And the wording in the text beyond this diagram, it's very careful. It says, we do not wish to encourage ICS-LABA use. That's the exact wording. So again, we don't say that there's a downside, but if you decide to use ICS-LABA, then rapid escalation to triple therapy during follow-up is what we would advocate. Now, during follow-up, we on purpose do not state the level of exacerbations at which you should escalate. That's your judgment. And there are debates about this. Is it 1 exacerbation? Is it 2 exacerbation? My view would be 1. We can debate it, and you can find a level you're comfortable with. But I will point out to you that 1 exacerbation has a mortality signal, and that's why my personal view is 1. So I showed you the different triple therapies, and clearly you have a choice. So I'm going to move beyond the GOLD view and give you my personal view of how to choose between inhaled corticosteroids. I'm sure you're all aware of this. All drugs have a dose-response curve. In both asthma and COPD, the biggest response to an inhaled steroid is making sure your patient takes a low to medium dose every single day. So that's what we call a steep dose response curve. Once you move to medium and high doses, the shape of the curve flattens. And what happens at these higher doses is the benefit is small, the incremental benefit is small, but the side effect risk goes up. So you have to think about that very carefully. The fancy pharmacological term is therapeutic index, risk, benefits versus risks. And although you don't think about therapeutic index in your daily practice, you subconsciously think about benefits versus risks. And we now understand a lot more about the mechanism of inhaled steroid risks. And we put these together in a review in the European Respiratory Review last year. There is very good mechanistic information from multiple experiments that inhaled steroids alter the way that the phagocytes in the lungs behave. So macrophages and neutrophils, they remove bacteria. And inhaled steroids subtly alter and reduce macrophage phagocytosis. The airway epithelium provides a first line of defense against bacteria and viruses. And again, inhaled steroids cause subtle changes in the peptides and molecules, including interferon, that provide the host defense. So we should bear that in mind. So I showed you earlier that the benefit of triple therapy against dual bronchodilator in the Tribute study was a 15% exacerbation rate reduction. And overall in the study, this was 52 less exacerbations. But it comes at a price. There are 3 pneumonias extra. So this is extra fine beclomethasone formoterol glycopronium. The dose of inhaled steroids per day is 400 micrograms. By lowering the dose to this medium dose, we can reduce the incidence of pneumonia. We have to be careful when we look at pneumonia events across studies because they are diagnosed in different ways. So a note of caution. Sometimes it's just physician reporting. Sometimes there's an X-ray to support it. Sometimes there's an adjudication committee. And the rate goes down as you put more rigor there, when you have an X-ray, when you have an adjudication committee. So over the years, we see a variation in pneumonia rates, and so we shouldn't really compare across studies. But nevertheless, when you look at the studies with lower doses of steroids, such as the extra fine formulation with beclomethasone, you do tend to see lower pneumonia rates. So let's look at that a bit further from real-world data. So here's one real-world study of extra fine inhaled steroids using asthma or COPD versus non-extra fine, so fine particles. And just to clear up, extra fine are particles less than 2 microns, and fine are particles 2 to 5 microns. And you see this 40% reduction in the odds ratio of suffering with pneumonia. Now, this is asthma and COPD patients. Let's go further. Real-world evidence, and again, we have limitations here because it's retrospective, and we do here have propensity matching, but you can never quite, in real-world data, remove all the biases which you may not be able to see. But nevertheless, let's look at the data, and this is extra fine beclomethasone versus fluticasone-based combination, so fluticasone propionate or furoate, and I'll show you it's split out on the next graph. We have pneumonia defined sensitively or specifically with an X-ray. I also show you information for respiratory tract infections. Focusing more on pneumonia, we see that there's an increased hazard ratio of pneumonia if you use a fluticasone containing, even in the propensity matched and even in the specific definition population. And with that, there's actually more upper and lower respiratory tract infections. And when we split it out, there's a lot of information on this slide, but generally the pattern is there for both types of fluticasone, the older propionate or furoate, which is more potent and is once a day. So I find this very interesting. There may be an assumption that corticosteroids are very identical, but they're not. They have different pharmacological properties. Fluticasone furoate was designed as a once-a-day formulation. It's an extremely potent molecule that hangs around in the lungs for a long time. For some patients, giving a lot of beneficial effects. The problem is, for other patients, the high potency and hanging around in the lungs for a long time, and it hangs around because it's highly lipophilic, may result in bacterial overgrowth, which gives pneumonia. So there seem to be two mechanisms here that we can manipulate in our practice if a patient's at underlying risk of pneumonia. We think carefully about the dose, and we should not be using high doses of inhaled steroids. Thinking about small airway deposition with extra fine formulations can modify the dose to achieve efficacy, but without unnecessarily increasing the pneumonia risk. And then this property of lung residence time and lipophilicity can be a problem for fluticasone furoate in selected patients. So I want to move to the last part, because where we are moving now then in terms of control and stability is very much a personalized approach. And Gold, a number of years ago, introduced the use of blood eosinophil counts to help us decide who would have the biggest response to inhaled steroids. Now, in my view, I think this has become overly complicated. This is not rocket science. Some patients with COPD have type 2 inflammation, and they respond better to inhaled steroids. And a blood eosinophil count is a simple test that tells you who has more type 2 inflammation. The magic number is approximately 100. It's somewhere around there, 100, 150. The way to think about it is below this level, patients don't have type 2 inflammation. And if you see patients with consistent counts below that level, they don't have type 2 inflammation. Above this level, they may have type 2 inflammation, and as the count goes higher and higher, they probably have more of it. People have focused very much on the 300 number, and actually 300 is the number at which you're virtually sure inhaled steroids will work. And here's a bronchoscopy study we did, lower than 150 versus higher than 250. And we found the higher than 250 group had a lot of type 2 inflammation. A number of markers, including interleukin-13, are raised in the lungs of patients with higher blood eosinophil counts. And eosinophils themselves are probably not the prime target of inhaled steroids. We did a literature review of all the randomized control studies with a placebo group that have biopsied the lungs, and actually inhaled steroids don't reduce the eosinophil counts in bronchial biopsies. What they do is reduce the mast cell counts and lymphocyte counts. So inhaled steroids have an effect across type 2, and eosinophils are just telling you who has type 2 inflammation. And this is Alvar's paper. At that other end, less than 100 eosinophils, there's something going on there with reduced host defense, bacterial colonization, and this fits into the at-risk population who get bacterial infection and are at risk of pneumonia. And in a simplified version, you might want to look up this Gold 2022 review that puts the patients on a spectrum at the one end with higher eosinophil counts with type 2 inflammation who do well with inhaled steroids, and you can achieve stability with triple therapy. And at the other end, patients with low blood eosinophil counts who have a poor response to inhaled steroids, and the use of inhaled steroids may increase their risk of bacterial infection and pneumonia events. So I seem to have lost my summary slide, but I can give you my conclusion. We're thinking about control in this symposium. GOLD focuses very much on controlling symptoms now and future risk. And control, stability, future risk, these are all overlapping concepts. For patients with exacerbations, in a personalized manner, the best chance of achieving control is with single inhaler triple therapy. And you should think very carefully about concepts like dose and differences between molecules to prescribe the best triple therapy for your individual patient. Thank you for listening.
Great. So thank you very much for the invitation. I'm delighted to be on this stage, and you've heard me talk about small airways before, and on this occasion, I challenged myself to find the evidence of small airways related to COPD control, which is the theme in the next 20 minutes. And I'll give you my summary slide now. So we started off by seeing Alvar's paper on personalizing and COPD control. And I want to present to you that the small airways is a phenotype, and the small airways is a comorbidity, and we need to treat the small airways in order to achieve control. The second point I want to reiterate in my presentation is we mustn't forget the heterogeneity and the variability that we see as COPD clinicians every day in our clinic with the patients. And you've seen this heterogeneity and variability in the richness of the presentations, the last two presentations. And I will focus on structure-function relationships of the lung and try and move this forward. So this is a state-of-the-art review that we undertook with Jim Hogg and Mei-Lan Han a few years ago, and it goes through the 7 pillars, the 7 Ps of small airways disease. And what I will do is I will pick information and also new data that presents the foundation that you and I need to think about assessing small airways, considering small airways, and also treating small airways. So let's start off. Pathophysiology. Jim Hogg has clearly shown over the last 50 or 60 years his work on small airways and in COPD, and you are clearly aware from this publication over 20 years ago now in the New England Journal of Medicine that actually was very innovative at the time. 3 key messages that you can see: that small airways inflammation is present even in mild disease. So it's not just severe or moderate, it's present in mild disease, and you can see that on the bar chart. The second key point, the inflammation worsens with worsening disease severity, and we've seen evidence of that in some of in the previous presentation. And finally, look at this, the presence of eosinophilic inflammation at all stages. Now, a key point, when I talk about small airways, I'm not talking about the acinar component from 17 to 23. I'm talking about the small conducting airways that are generation 7 to 17, the terminal bronchioles. This is an area that you and I forget. This is an area that contributes to the silent zone. And so just a year ago now, in mild COPD, we can clearly see now the single-cell atlas information. And if you look on the right-hand side, the staining is for actin and the staining is for elastin. And it's really quite clear now that when you look at the terminal bronchiole level, generations 15 to 17, and as you would naturally expect in the acinar component, the increased level of laying down. And so this now links to this whole point, and this concept that we've had is that you get disappearance of the small airways before you get the presence of the emphysema, and the richness of the information that we're seeing in the last 2 years is adding to those visible findings that we saw pathologically. So we know now that the small airways are the major site of airflow limitation. You and I see that every day. Hyperinflated lung fields, flat hemidiaphragms on the chest radiograph. It's the small airways that are involved, raised RVTLC. And this leads to the trajectory, again, of air trapping, of hyperinflation, of dyspnea. And we saw very clearly dyspnea is what our patients are complaining about when they come and see us. They don't say, I've had 1 or 2 exacerbations that's bothering me, and we are interrogating them, so you now see dyspnea and exacerbation in the gold directive, and it has been presented. Now, for me, this is the most important slide, and I thought of this because I presented in Spain before on small airways. I want to put it to you, 5 Valencian stamps is 20 centimeters squared. It's this post-it note. Do you think this contributes, this area, to everything that you and I see in our patient, all the inflammation, and our treatment is just targeted to this area? Now, multiply this by 200 times, and you get the area up to the terminal bronchioles. That conceptually, to me, contributes to our patient's symptoms, yet the treatment that we target is just predominantly to this area. And then, obviously, we have the acinar component, which is half a tennis court and 80 meters squared. That's mainly involved in gas exchange, and that's not where I would say, as an aerosol scientist, the majority of our treatment needs to go in managing COPD, but yes, it needs to go in alpha-1 antitrypsin deficiency, and there's inhaled therapy now that's being targeted. This is from Weibel, the famous pathologist's thesis from 1963 and an interpretation in 77. And I counted all of these generations, and I counted the area. Surely this area cannot be contributing to the patient that I see. Surely just treating this area is not right. We need to consider that zone from 7 to 17, which we totally ignore in our patients. That, for me, was the most important slide. So moving on, probing. Again, time doesn't permit me to talk about probing, but in the last decade, we've improved in our biological assessment, our imaging assessment, and also our physiological assessment. And this morning, I saw on LinkedIn that the oscillometry workshop was completely packed. And I think oscillometry should, in hopefully a decade or 15 years' time, replace spirometry, but for the time being, what we have is spirometry. So I came back, and I think my second slide, and again, rethinking, is it's the heterogeneity that we see in our patients. The heterogeneity of the inflammation. It's not all congruent. You may have something in the right upper lobe, some bronchospasm in the middle lobe, some inflammation here, mucus plugging. So your treatment needs to spread across this area. But then you've got erratic flow. So you need to overcome the flow. And the way that you can do it from aerosol science is 2 ways: by changing the particle size or changing the flow of the aerosol. A slower flow gives you a better spread throughout the airway tree. So this concept of ventilation heterogeneity, which has been around for 40 years, again, we need to rethink in COPD, and it is being investigated now, and you'll be aware now of parametric response mapping. That's now Craig Galban from Boston in 2012 actually started, and every year we see the build-up of evidence now in looking at the different patterns on imaging. So here is FSAD, functional small airways dysfunction, and emphysema. This is sophisticated software that can tell you now beyond the HRCT of looking at 2 millimeters in diameter and beyond. And it can really give you an assessment now of this heterogeneity and the different subtypes, the different phenotypes, the different personalization that we need. Oscillometry is the way that the lungs work naturally. Spirometry measures the lungs in an abnormal way. No other discipline in medicine does this. We stress the lungs out, and then we take the FEV1 and the FVC, and we start off with that as our measurement. I put it to you, I think it's crazy, but that's what we do. Oscillometry, 30 seconds, tidal breathing, that's how the lungs work. The cardiologists don't stress the heart and do an echo. They measure the heart at rest, and then they do dynamic stress, and then they look at the delta between the resting heart and the stressed heart on echo. Again, time doesn't permit me, but now we are seeing minimal clinical important difference from Friedrich Treatment's group in asthma, and now he's doing work on COPD. So this is with Klaus Rabe, and Friedrich's group in Heidelberg, where they're now looking at capto-COPD. This is a 2-year study looking at COPD patients. And this paper, I understand now, is possibly in publication. And here they're clearly showing which of the indices now in oscillometry are related to the COPD state and can actually look at control and look at exacerbation and dyspnea and the CAT score. And what you can see here in the bar graphs is that the oscillometry indexes are better than RV-TLC and also better than our conventional spirometry in COPD in smokers at risk. Reinforcing mild COPD is important. And we've all said by the time they're in stage 4, it's too late. It's early consideration of small airways dysfunction. Prevalence, we know this data from Crisafulli when he looked at using oscillometry, and now this R5 resistance at 5 Hertz minus R20 resistance at 20 Hertz. So very briefly, when you pulse at very slow pulses via the oscillometer, you get assessment of the whole airway tree. And when you pulse fast, you get an assessment of large airways, and the difference, you can work out the small airways. The beauty of oscillometry is you know what, you can use it for vocal cord dysfunction in asthma patients, so you don't need to send them now for nasoendoscopy and stress the cords and look for apposition of the cords or reduction. Oscillometry allows you to do this, but it also gives you large and small airways. So based on this, look at this, 50% going up to nearly 100%. So in mild, we mustn't forget the presence already of small airways dysfunction. So, if we believe our pathologists who've told us for 50 years, wake up pulmonologists, why are you ignoring the small airways? If we believe the physiological data, if we now have a sense that we can touch the small airways and we can assess them, then how can we target the large and small airways? And you know this very easily. The problem is every day you and I use inhalers that just target this area and this area alone, and they're not great at targeting the intermediate area, the small conducting zones, which is 200 times size is posted. And that's the problem. And may I put it to you that this is contributing to poor COPD control. Now, the data has come from asthma, and Dave Singh was involved in the Atlantis data, where small airways dysfunction in asthma can actually predict now, prospectively over a year, your asthma attack and your asthma control. And we're seeing this data now from capto-COPD from Germany. So as part of my PhD, I asked the scientific question, if you change the size of the particle, this was independent PhD, can you achieve two things? One's the efficiency of drug delivery to the lungs, because I thought, do you know what? All these inhalers are highly inefficient, and that relates to what Dave was talking about, was the dose response, because so at best, your inhaler, 10 to 20% goes in the lung. So you have to dose high in order to achieve 20% in the lung. So most of our drugs are on the top of the dose response range, and more the reason for what he was saying makes sense in terms of using the lowest dose possible for the maximal gain and improving the therapeutic index. So you can clearly see that when you use small particles or extra fine, less than 2.1 mmAd, and extra fine has been defined now in the literature on bench aerosol science data, you get two things. One, greater deposition in the lung, and it spreads throughout the central and large airways. Look at the 6 microns, 6, 5, 4, 3. What do we see? Hotspots. What do those red hotspots tell me? That aerosol is being trapped where there is narrowing. The narrowing could be inflammation. The narrowing could be mucus. The narrowing could be bronchospasm. The heterogeneity that I showed you. They're not able to traverse beyond these obstructions to at least spread the ICS LABA and LABA, if it's a triple therapy, across this carpet of inflammation to allow the treatment. And following on from what Dave said, it is the spread of this treatment across the whole airway tree that prospectively allows you to lower the dose of the ICS and achieve better control. We've shown this for COPD as well. And this recently we showed using the technique of FRI. Now, functional respiratory imaging takes CT scans of patients, and in this case with COPD, and superimposes a model of computational fluid dynamics where you compute particle size, flow, and various characteristics related to the inhaler device. Now, the P to C ratio takes out the variability in the P, the peripheral zone, the variability in the deposition in the sea, and allows you to get an estimate of penetration of the aerosol throughout the airway tree. Now, you can see on the left-hand side, and you've seen these images before, extra fine beclomethasone, formoterol glycopyrronium trimbo. Visually, you can see it spreads. So this study follows the gamma scintigraphy aerosol science of a small particle being able to reach not just the small but the large airways. In contrast, when you use a larger particle, here was a dry powder inhaler, and this was fluticasone furoate, vilantrol, and umeclidinium, you can see very good at the central, but not so great in spreading throughout. And you can see that in the table on the bottom, on the CP ratio. The lower the ratio, the better the penetration throughout this mucosal carpet of inflammation and mucus and bronchospasm. The higher the ratio, the more centrally it's orientated. So I move on now, and actually into the last 5 minutes, so I think is inhaler technique. This is the largest systematic review to look at inhaler techniques. And what's important is I use this document now to policymakers and governments. Why? Because I say just one inhaler error, one error, is a cost to the patient and is a cost to the society. Cost to the patient, loss of control, exacerbation. Cost to the society, well, you know that. The society has to pay for the hospitalization. Related to the error, not the drug alone, the error of the inhaler. So if we look, what is the cost to the patient? Well, this was the pivotal study done by Jan Willem Cox, and in a large study across the globe, they looked at the suboptimal peak inspiratory flow. Now, we may think, do you know what, dry powder inhaler device is really easy. All you need to do, Bob's your uncle, that's great, done and dusted. It's actually not as straightforward as that. 30% of patients have suboptimal peak inspiratory flow. And this has now been consistently shown in different methods, in very sophisticated methods where you have electronic monitoring of the device. And Richard Costello clearly showed that actually there is prevalence of suboptimal peak inspiratory flow. So not only is adherence an issue, but also the technique of that patient to inhale properly. So this is a cost to the patient. This is a cost to society. So this, you again will be familiar, I'm sure, of this paper. It's comprehensive in its analysis of looking at dose, of particle size, and looking at extra fine versus non-extra fine. Time doesn't permit me to go through all the evidence here, but this reinforced that actually if you have extra fine, you are better in your days to the first exacerbation. There wasn't that much of a difference between pneumonia, although it was 3% in extra fine and 4.3% in non-extra fine, but the health economic analysis, logically, because you're using extra fine to spread, therefore you're lowering the ICS dose, you're improving the therapeutic index, you can see that the treatment costs were lower because of the direct and indirect costs were lower because there were less exacerbations. So it pragmatically follows the science. Patient outcomes, one slide to show you that in that study by Crisafulli, they looked at the COPD assessment test score, and there was a direct relationship between small airways disease and non-small airways disease. So small airways, there as the CAT score goes, is clearly related. And this is the St. George's Respiratory Questionnaire. And I show this from Haruna, and it's an old data, but I show it for two things. Oscillometry of the small airways was more significantly correlated with the health status than the traditional FEV1. Makes sense. FEV1 only measures this area. This oscillometry measures the small airways, that 200 of these post-it notes. So finally, I think this is just 3 slides. How do we make sense of this all? What are our prescribing decisions? And I come back to work done by somebody very familiar to you, Vicente Plaza, and 2 studies by him. So the first was, he said, we are all rubbish in inhaler knowledge. As clinicians, as pharmacists, as nurses, as physiotherapists, as medical students, shockingly only 12% of us know how to teach our patients. So the problem of control doesn't lie with our patients, it's because we lack the knowledge. Now, we're all educated and articulate. We learn about cytokines, we learn about receptors, we learn about pharmacology, we learn about all the different phenotypes, subtypes. Why can't we just learn about 5 different devices and how they work? So this is a wake-up call to those of us who are involved in medical, nursing, physiotherapy, pharmaceutical education, to go to the deans, to enforce or instill those that train as respiratory specialists to have training in devices. Because every day you and I write a prescription, 50% of it is a device, whether in the intensive care unit and it's a nebulizer, or it's a COPD specialist and it's triple therapy, or whether it's in the community as a pediatrician, you are giving a device. So this is the final slide. It's now been shown in asthma that people say, look, we don't have oscillometry as a sophisticated technique. So I say use FEV3, FEV6, and FVC in your spirometry. And some people say, we can't do that. So this, again, was by the GEMA Forum group here, by Vicente Plaza, and said the highest Delphi agreement of 85%, if you suspect small airways dysfunction, a therapeutic trial with drugs for that patient, and review after 4 to 6 months. And if it's not working, at least you have looked into that phenotype, looked into that comorbidity, addressed it in the same way that we do with nasal, with pollution, with environment, with the dusting the sheets in asthma, with the heart disease, with the osteoporosis, with the anxiety, with the depression. So in summary, I put it to you that I have challenged myself to bring out aspects of small airways that are reflective of the control theme that we have in the session today. And the final slide I show you is probably a lamb in a lion's den, but I just humbly want you to consider thinking about how you vote. On that note, thank you very much for your attention.
Thank you very much. Muchas gracias a los tres ponentes. Let me start by a question in Spanish to Dr. Soler. Juanjo, tú sabes que yo creo en el clinical control, pero hay una manera que me ha parecido a mí que interpretabas los datos que me ha sorprendido. Tú has dicho, si un paciente tiene más actividad, eso resulta en mejor control.
No.
¿Y si es al revés? Es decir, gracias a que tienen mejor control, tienen más actividad.
Sí, claro. Efectivamente, tienes razón. El estudio es transversal y no establece la dirección de la relación. Simplemente lo que viene a sugerir es que aquellos pacientes con más actividad física tienen mejor control.
Pero
no sabemos si
¿es antes el huevo o la gallina?
Claro, esto no lo sabemos. Por eso necesitamos siempre estudios longitudinales para ver. Pero sugiere que la actividad física es buena porque vas a tener un buen control.
Eso lo sabemos, ¿no?
Claro.
¿Y la comorbilidad? ¿Cómo se cuenta la comorbilidad en el clinical control?
Bueno, realmente no figura la comorbilidad como un ítem apartado, pero sí la lectura es que todas las enfermedades concomitantes, la mayor parte de las enfermedades concomitantes que hemos visto en estos pacientes graves tienen un impacto clínico. Y por eso afectan, otras también tienen impacto sobre la estabilidad, pero por eso fundamentalmente afectan al control. El mensaje, de nuevo, es un estudio transversal. Por lo tanto, no sabemos la dirección, pero podemos presumir, y esta es la hipótesis, es que lógicamente si tú eres capaz de actuar sobre las otras distintas enfermedades, podrías mejorar el control y viceversa. Si tú eres capaz de actuar sobre la propia EPOC con otros fármacos, con otros mecanismos, podrías mejorar el impacto sobre las otras enfermedades.
¿Es posible entonces que un paciente EPOC esté mal controlado? No por la EPOC.
Efectivamente. Es que la herramienta control, ahora quizás en el simposio estamos trasladando control, incremento de medicación. No necesariamente. La herramienta se diseñó y el primer mensaje es, mire, esto sirve para que usted se dé cuenta de que esto no está bien. Y por lo tanto, si usted tiene un paciente no controlado, el primer mensaje es busque por qué no está controlado. A lo mejor es porque le falta medicación, a lo mejor es porque no tiene una buena adhesión terapéutica, a lo mejor es porque una técnica inhalada no es correcta o a lo mejor es porque tiene una enfermedad cardiovascular concomitante. Entonces, a partir de aquí, identifique y corrija lo que deba corregir. En algunos casos, también servirá para que sirva para aumentar la medicación, ¿no? Pero no es el único concepto, sino que el mensaje es aquí algo falla, ¿no? Vamos a ver qué ponemos en marcha.
A mí me parece que eso es un mensaje muy importante, porque si no puede ser, mal controlado, más corticoides, por ejemplo.
Permíteme, hay un estudio que no está publicado que habla de los rasgos tratables. En nuestra corte quisimos ver los rasgos tratables cómo influían sobre el control. Y como era un estudio observacional, teníamos en nuestra corte rasgos, identificamos 5 o 6 de los relevantes y veíamos cuáles estaban siendo tratados y cuáles no estaban tratados. Aquellos pacientes que tenían la misma gravedad de la enfermedad y recibían o estaban tratándose esos rasgos tratables, tenían mejor control que aquellos que no estaban diciendo. Todo va en la misma dirección, pero de nuevo nos hace falta estudios de intervención, ¿no?
Dave, may I ask you? Dr. Soler, when he presented his clinical control questionnaire, clearly showed that you have to consider 2 dimensions, impact and stability. You basically talk about stability as a surrogate for control. Can you use it that way? Shouldn't you also be considering impact? Can you assume that disease stability can ignore the impact of it? If I have a patient who's very symptomatic, big impact, and the best I offer him or her is, well, don't worry, you will be stable. That might not be a very good idea.
So just to clarify, I was talking about stability as one of the components of control. I was not talking about it as a surrogate overall for control. And unfortunately, I seem to have lost my first and last slide, and I don't know why. My first slide actually had the gold diagram, which says the 2 aims of treatment are to improve symptoms today and reduce future risk. And so I was going to cover that off by saying that a key component is to improve.
So we agree that there are 2 components.
Absolutely.
Okay. Patricia, ¿quieres tú?
Bueno, veo que no se anima nadie. Yo voy a empezar por Juanjo también.
Vaya.
¿Tenemos datos de si se ha implantado la herramienta? Es decir, ¿la usamos nosotros, neumólogos?
En la última encuesta, auditoría de EPOC se ha analizado el control, pero no se ha analizado, no sé si está Miriam por aquí, que es la que lidera el proyecto, no recuerdo en estos momentos si analizábamos el uso del control, porque lo que quisimos saber era, aunque el control no estaba, introdujimos una serie de preguntas para ver si determinábamos el control. Y de esa forma saber los datos que os he presentado, que aproximadamente estos pacientes, por ejemplo, los pacientes de bajo impacto, de acuerdo a SEPAR, tienen un control casi en el 80 y tantos %. Y los otros bajan. Y entre los fenotipos no hay grandes diferencias. Están alrededor del 30-40% parecido al clave, ¿no? Pero no si está siendo utilizado el concepto de control todavía por nosotros. Recordar que la propuesta de uso a través de SEPAR es publicación de enero del 22. Esto probablemente para la siguiente auditoría lo sabremos. Yo espero y deseo que pueda ser utilizada, pero bueno, estamos un poco...
Juanjo, pero volvemos al huevo y la gallina. Si la definición de control es bajo impacto y estable,
Sí.
y tú defines control con estos 2 conceptos, y luego me dice, y los que están controlados tienen menos síntomas y menos agudización. Hombre, claro, si lo has definido así, ¿cómo va a ser al revés?
Bueno, sí, tiene influencia, pero por ejemplo, en la definición original también se arbitra la alternativa, que es utilizar el control únicamente por cuestionario CAT como alternativa, donde el impacto son 10 o 16 en función de la gravedad y el cambio. Y se demuestra prácticamente lo mismo. Es decir, que aquellos pacientes que están controlados van a tener mejores resultados, que están controlados de acuerdo al CAT, no de acuerdo a las variables clínicas. Pero tienes razón que las agudizaciones impactan, o sea, Todos sabemos que el principal determinante de futuras agudizaciones es tenerlas previas. Esto es aquí. Pero recuerdo que aquí hablamos de las agudizaciones de los 3 últimos meses, no el historial previo de agudización.
Lo cual quiere decir que has de visitar al paciente cada 3 meses.
Bueno,
Porque si no, de aquí a un año, los últimos 3, ¿cómo ha estado?
no necesariamente. Es cierto que a la hora de valorarlo tú haces referencia a cómo está recientemente, pero desde el punto de vista de la gestión, que es otra aplicación de la herramienta, permitiría ver que aquellos pacientes que tú no tienes controlados seguramente son los que necesitas ver con más frecuencia.
Por alusiones, Bernardino. Ah, ¿no?
No.
Entonces calla, no digas
Callo.
nada.
Quiero preguntar. Omar, congratulations for your talk. Just 2 questions. We don't tend to measure the peak inspiratory flow in patients with COPD in the everyday clinic, okay? So what is your perception about the relationship between peak inspiratory flow and the occurrence or the incidence of exacerbations in COPD? I know you have been working on that. And the other question is about smart inhalers. Should we include them in our normal healthcare? Should we have them available in order to detect those patients who have incorrect or inefficient inspiratory flow?
So there are 2 great questions. I'll start with the second one. So the role of smart inhalers, I see, because everybody says to me, you know what, inhalers, 50 years you've been talking about adherence and it's a problem. And we saw the data, 40%, 35%. You know, adherence, you know, I can't solve this problem. So the role for smart inhalers is the first time that you see a patient and you give them an inhaler is to utilize the smart digital approach to actually train them properly. Because we, as I've shown you, are very bad at training our patients, and the smart inhaler will be able to. And there are now inhalers that actually will guide using AI technology patients to lift the chin up and to inhale with a clock and a timer, and it's all very nicely done. So the first point, why? Because we need to build that psychological, that Pavlovian behavior on making sure that you have that conditioned good response. So I'm actually doing a study for the FDA at the moment on a huge grant to look at the psychology of inhalation from dry powder inhalers. It's a 5-year grant, and they've spent $2 million because it's from the generics group, and they are very concerned about this whole area of smart inhalers and poor peak inspiratory flow. So that leads me to the first question. We should. And I am actually doing work now to try and dissect out the pharmacology from the pure use of the inhaler and the technique, not the compliance, not the adherence, but the technique, and prospectively look at the group that has suboptimal flow and their admission to hospital. Now, there are 3 pieces of data in the last 4 years. The first one was from a Singapore consultant who went to the US. He showed that on discharge in hospital in the US, he looked at 2 groups, those that were discharged on a dry powder inhaler, those that were discharged on a nebulizer, because in the US they use nebulizers a lot, and in 3 months the 50% readmission rate was greater in DPIs. And in the US, if more than 20% of your population of COPD is readmitted, your hospital gets penalized, it gets fined because of the insurance system that's actually set up. And I think, look, you've had a patient come in with an exacerbation, they've got a high respiratory rate, they're in hospital for 2 or 3 days, and then you're giving them an inhaler where you expect the respiratory muscle strength to activate the inhaler. It doesn't make sense. So in that situation, I always prescribe a metered-dose inhaler plus a spacer and or a soft mist inhaler. So we should measure, and there are tools to measure, and those people that say we can't, there's a surrogate of the hand grip strength that you can utilize as a measure of which DPI is suitable for your patient.
Omar, is that paper published?
Yes.
The one on readmissions, I mean?
Yeah, Jill O'Hare and 2019.
Oh, that's interesting.
And there's 2 other papers now that have been published.
Would you mind to send them me?
Yes, sure, no problem.
Última pregunta, doctora Sobradillo.
I'd like to send a last question to Dr. Singh. Just very briefly, you showed very clearly that fortunately we've been using less corticosteroids in our patients during last years. But does the GOLD document state clearly that we should use low doses of corticosteroids in our patients?
Yeah, so it's a good question. In the gold document, we have a section on inhaled steroids, and we do say that you need to use appropriate doses, and we list the side effects. We were discussing this at dinner last night. The problem with the gold document is people look at the diagrams, not the text.
Thank you. Pues vamos a cerrar el simposio. Muchas gracias a todos y que tengáis un buen congreso.